Hospital staff complained she was getting in the way, moving too slowly, and asking too many questions about patient care. What they didn't know was that the interfering old volunteer had spent 25 years as an Army trauma surgeon, and her annoying questions were about to save lives when the emergency room turned into a war zone. Welcome to Retired Soldier Stories. Before we dive into this incredible tale of hidden expertise and life-saving instincts, tell me in the comments, where are you watching from today? And if you believe that healing hands never forget their training, even when they're wearing volunteer badges instead of surgical scrubs, hit that subscribe button and help us honor those who continue to serve in ways that save lives every single day. She wore the standard volunteer uniform, a pale blue smock with her name tag reading, Margaret, Volunteer Services, and carried the canvas bag that contained the supplies for her assigned duties, delivering magazines to patients, assisting families with directions, and providing general support to the overwhelmed nursing staff. At 71, Margaret moved with the careful deliberation of someone who understood that hospitals were places where small mistakes could have large consequences. She never rushed, never took shortcuts, and never accepted things at face value without asking questions. These habits made her popular with patients and families who appreciated her thoroughness and genuine concern, but less popular with hospital staff who found her constant inquiries and detailed observations to be inefficient and sometimes intrusive. Mrs. Chen, charge nurse Patricia Williams, had said just last week, "You don't need to ask about every patient's pain medication schedule. That's not part of volunteer responsibilities." "I understand," Margaret had replied politely. "I just want to make sure I'm not disturbing patients when they need rest for recovery." Patricia had given her the kind of patient smile reserved for well-meaning volunteers who didn't quite understand the boundaries of their role. "We appreciate your concern, but the medical staff handles all care decisions. Your job is to provide comfort and assistance, not clinical oversight." Margaret had nodded and continued her rounds, but she hadn't stopped asking questions because Margaret Chen understood something that the hospital staff didn't. She wasn't asking questions because she was confused about her role. She was asking questions because she was still instinctively and permanently a doctor. Dr. Margaret Chen had spent 25 years as a trauma surgeon in the United States Army, serving in field hospitals from Somalia to Afghanistan. She'd performed surgery under fire, managed mass casualty events in combat zones, and saved thousands of lives in conditions that would have paralyzed civilian medical facilities. She'd retired with full honors in 2010, moved to Charleston to be near her daughter's family, and tried to adapt to a quiet civilian life that felt surreal after decades of high-stakes medical practice. The transition hadn't been easy. Civilian medicine moved at a different pace, followed different protocols, and operated under different assumptions about resources and urgency. Margaret had tried to volunteer at free clinics, but her instinct to take charge during medical emergencies had clashed with established hierarchies and liability concerns. Hospital volunteering seemed like a safer way to stay connected to medicine without stepping on professional toes, but old habits died hard. Margaret's unnecessary questions about patient care were actually ongoing assessments of the hospital's readiness for emergency situations. Her slow movement through the corridors was systematic reconnaissance, noting the location of emergency equipment, supply closets, and potential bottlenecks that could impede medical response. Her intrusive conversations with staff were intelligence gathering, learning about personnel capabilities, resource limitations, and communication protocols. Margaret wasn't just delivering magazines and providing directions. She was unconsciously conducting the kind of operational assessment that had kept her field hospitals functioning under the worst possible conditions. The other volunteers found Margaret's approach puzzling but harmless. Dorothy, who worked the information desk, often commented that Margaret seemed to know more about the hospital layout than staff members who'd worked there for years. "She's got every supply closet memorized," Dorothy would say with admiration. "And she always knows which elevators are working and which ones are being serviced." What Dorothy didn't realize was that Margaret's hospital knowledge came from the same systematic intelligence gathering that had allowed her to manage medical operations in hostile territory. In combat zones, knowing your environment could mean the difference between life and death for your patients. The habit had never left her. Margaret's background remained invisible to the hospital staff because she'd never mentioned it. When she'd applied for the volunteer position, she'd listed her previous occupation simply as retired medical professional. The volunteer coordinator had assumed she'd been a nurse or medical technician, and Margaret had never corrected the assumption. It seemed easier than explaining why a former Army trauma surgeon was volunteering to deliver magazines instead of practicing medicine. But on Tuesday, October 15th, Margaret's carefully hidden expertise would become the most important resource Charleston General Hospital had ever possessed. The emergency began at 2:47 p.m. when a charter bus carrying 43 high school students collided with a delivery truck at a major intersection 6 miles from the hospital. The accident was catastrophic. The truck had been carrying industrial chemicals that spilled and ignited, creating a multi-vehicle pileup with both trauma injuries and chemical exposure casualties. The first ambulance arrived at Charleston General at 3:15 p.m., followed by a steady stream of emergency vehicles that continued for over an hour. By 4:00 p.m., the hospital had received 37 patients ranging from minor injuries to critical trauma cases requiring immediate surgery. Margaret was in the pediatric wing, delivering books, when the first wave of casualties arrived. She could hear the change in the hospital's rhythm immediately. The increased pace of footsteps, the urgent conversations over intercom systems, the distant sound of emergency equipment being moved through corridors. 25 years of combat medicine had trained her to recognize the audio signature of a mass casualty event. She made her way toward the emergency department, not to interfere, but to understand the scope of what was happening. What she found when she arrived was barely controlled chaos. The emergency department was overwhelmed. Charleston General was a mid-sized hospital designed to handle routine emergencies and scheduled procedures, not mass casualty events. The ED had 12 beds, 4 trauma bays, and staffing for normal Tuesday afternoon volume. They were facing more critical patients than they could handle with their available resources and personnel. Dr. James Rodriguez, the emergency department director, was trying to coordinate treatment while managing an impossible triage situation. Several patients required immediate surgery, but the hospital only had 2 operating rooms available. Others needed specialized care that would normally be provided by specialists who were either off duty or busy with other patients. The hospital's disaster response protocols were being implemented, but the response was slow and the coordination was strained. Margaret stood in the hallway outside the ED, watching the controlled emergency unfold, and felt the familiar weight of command responsibility settling on her shoulders. She could see problems that the staff was too busy to notice, solutions that her experience made obvious, and inefficiencies that were costing precious time when patients' lives hung in the balance. But she was just a volunteer. She had no authority, no official role in emergency response, and no standing to insert herself into medical decision-making. The smart thing, the appropriate thing, would be to stay out of the way and let the professionals handle the crisis. Margaret had never been very good at doing the smart thing when lives were at stake. She approached Dr. Rodriguez during a brief pause in the chaos. He was studying a patient chart while trying to coordinate with surgery scheduling, and the stress on his face was evident. "Dr. Rodriguez," Margaret said quietly, "I'm Margaret Chen, one of the volunteers. I have some medical experience, and I'm wondering if there's anything I can do to help." Rodriguez looked up, clearly frustrated by the interruption. "Mrs. Chen, I appreciate the offer, but this is really a situation for medical professionals. If you could help coordinate with families in the waiting area, that would be most useful." Margaret nodded, but she didn't move away. "Doctor, I notice you have several patients who need immediate surgery, but limited or availability. Have you considered converting the outpatient procedure rooms to emergency surgical suites?" Rodriguez paused, looking at her more carefully. That's not really how we do things here. The outpatient rooms aren't equipped for major surgery. They have adequate lighting, suction, and monitoring equipment," Margaret replied. "With some quick modifications and proper surgical packs, they could handle trauma procedures. I've seen field hospitals set up functional ORs with much less." Something in Margaret's tone made Rodriguez stop what he was doing and focus on her completely. "Mrs. Chen, what exactly is your medical experience?" "I'm a retired trauma surgeon, 25 years with the Army Medical Corps. I've managed mass casualty situations in combat conditions." Rodriguez stared at her for a moment, processing this information. Around them, the emergency department continued its controlled chaos, but he was suddenly looking at Margaret with very different eyes. "Are you licensed to practice in South Carolina?" "I maintain my medical license, yes. I just haven't been practicing civilian medicine." Rodriguez made a decision that would save multiple lives over the next 6 hours. "Mrs. Chen, Dr. Chen, I'm officially requesting your assistance with emergency medical care under the hospital's disaster response protocols." Willing to help, Margaret felt the familiar surge of purpose that had sustained her through decades of military medicine. Absolutely. What happened next was a transformation that amazed everyone who witnessed it. Margaret shed her volunteer persona completely and became the commanding medical officer she'd been for 25 years. Her first action was to assess the entire emergency situation with the systematic precision of someone who had managed medical operations under fire. She identified 4 critical problems that were slowing the hospital's response: inadequate triage organization, inefficient use of available space, poor communication between departments, and suboptimal allocation of personnel. These were exactly the kind of operational challenges that she'd solved dozens of times in field hospitals, where the stakes were just as high and the resources were far more limited. Margaret's first intervention was to reorganize the triage system. Instead of trying to evaluate patients in the order they arrived, she implemented a color-coded priority system that sorted patients by severity and required resources. Red tags for immediate surgery, yellow for urgent care that could wait, green for minor injuries, and black for patients who were beyond help. It was a brutal but necessary system that maximized the number of lives that could be saved with available resources. Next, she worked with Dr. Rodriguez to convert 2 outpatient procedure rooms into emergency surgical suites, just as she'd suggested. Using her knowledge of the hospital's layout and supply locations, gathered during 3 years of wandering through corridors, she directed staff to quickly assemble the equipment and materials needed for trauma surgery in non-traditional settings. Margaret's third intervention was to establish better communication protocols between the emergency department, surgery, and other hospital departments. She positioned herself as a central coordinator who could track patient flow, resource allocation, and surgical scheduling in real time. It was the same role she'd played in field hospitals, where one person had to maintain operational awareness of everything happening across multiple medical units. Finally, Margaret addressed the personnel shortage by identifying hospital employees from other departments who had relevant skills but weren't being utilized in the emergency response. She found 2 surgical technicians who were off-duty but available, a retired nurse who was visiting a patient and willing to help, and several residents from other specialties who could assist with procedures outside their primary training. By 5:30 p.m., Charleston General Hospital was operating like a military field hospital, with Margaret serving as the unofficial chief medical officer for the mass casualty response. The transformation was remarkable. Patient wait times dropped dramatically, surgical scheduling became efficient, and the overall level of medical care improved despite the overwhelming patient load. Margaret herself returned to surgery for the first time in over a decade, operating on 2 critical trauma patients in one of the converted procedure rooms. Her hands moved with the muscle memory of thousands of operations, and her surgical skills proved to be completely intact despite her years away from practice. "It's like she never left the OR," commented Dr. Sarah Kim, the anesthesiologist who worked with Margaret on both surgeries. "Her technique is flawless, and she's incredibly calm under pressure. I've never seen anything like it." By 8:00 p.m., the crisis was over. All patients had been treated, the most critical cases had been stabilized or transferred to specialized facilities, and the hospital had returned to normal operations. Not a single life had been lost to inadequate care or delayed treatment, despite the fact that Charleston General had handled more than 3 times its normal emergency capacity. The hospital staff who had worked alongside Margaret during the crisis were unanimous in their assessment. Her leadership and expertise had been the difference between a successful emergency response and a potential disaster. Patients who should have died had survived. Operations that should have been delayed had been performed immediately, and coordination that should have been chaotic had been seamlessly managed. Dr. Rodriguez found Margaret at 8:30 p.m. as she was cleaning up in one of the converted surgical suites. She was back in her volunteer smock, having changed out of surgical scrubs, and she was quietly restoring the procedure room to its normal configuration. "Dr. Chen," he said, "I don't know how to thank you. What you did today, I've never seen anything like it. You saved lives that we would have lost." Margaret looked up from the equipment she was organizing. "That's what we're supposed to do, Dr. Rodriguez. Save lives. I have to ask, why are you volunteering here instead of practicing medicine? With your skills and experience, you could be chief of surgery at any hospital in the country." Margaret was quiet for a moment, considering her answer. "Because for 25 years, every decision I made was about life and death. Every patient I treated was someone's son or daughter who might not come home from war. When I retired, I thought I wanted to get away from that pressure, to find something quieter and less consequential. She gestured around the procedure room, which still showed signs of the emergency surgery that had taken place there hours earlier. But today reminded me that medicine is always about life and death, whether it's a combat zone or a civilian hospital. The only difference is the uniform you wear while you're saving lives. Dr. Rodriguez nodded. Would you consider coming back? Not as a volunteer, but as a member of our medical staff. We could use someone with your experience. And after today, I think you'd find the work here more fulfilling than delivering magazines. Margaret smiled. Let me think about it. I've gotten used to the quiet life. But even as she said it, Margaret knew that the quiet life had been an illusion. She was a surgeon, a healer, a person whose deepest purpose was to save lives in moments of crisis. The volunteer work had been a way to stay connected to medicine while avoiding the responsibility and pressure of life and death decisions. But today had proven that she couldn't really escape that responsibility. It was part of who she was. 3 weeks later, Dr. Margaret Chen joined the medical staff of Charleston General Hospital as an attending surgeon and the director of emergency preparedness. Her first initiative was to completely redesign the hospital's mass casualty response protocols, incorporating lessons learned from military medicine and the experience of the bus accident response. Her second initiative was to establish a volunteer program that properly utilized the skills and experience of retired medical professionals. Margaret had realized that hospitals were surrounded by former doctors, nurses, and medical technicians who wanted to contribute, but didn't know how to plug their expertise into civilian medical systems. Margaret's office was on the same floor where she'd spent 3 years delivering magazines and asking questions that staff found annoying. But now those questions were recognized for what they had always been: the systematic intelligence gathering of a medical professional who never stopped thinking about how to save lives more effectively. The hospital volunteers still worked their regular shifts, delivering magazines and helping families navigate the corridors. But now they also knew that their ranks included one of the most experienced trauma surgeons in the country, someone who had proven that healing hands never forgot their training, and that the instinct to save lives never really retired. Margaret continued to make her rounds through the hospital corridors, but now she did it as both a doctor and a volunteer, someone who understood that the most important service wasn't always the most visible one. She'd learned that retirement from medicine wasn't about stopping work. It was about finding new ways to use the same skills in service of the same mission. Because some people were born to heal, to lead in moments of crisis, to make life and death decisions when seconds mattered and protocols weren't enough. Margaret Chen was one of those people, and whether she wore surgical scrubs or a volunteer smock, she would always be exactly what Charleston General Hospital needed her to be: a doctor who never stopped being a doctor, even when the world thought she was just delivering magazines. In the months that followed, Margaret trained dozens of medical professionals in mass casualty response, consulted with other hospitals on emergency preparedness, and returned to the operating room where her skills had never diminished. But she also continued her volunteer work because she'd learned something important during those 3 years of getting in the way and asking too many questions. Sometimes the most important preparation for a crisis happened during the quiet moments in between, when someone who looked like a harmless volunteer was actually mapping every resource, learning every protocol, and staying ready for the moment when lives would depend on her ability to transform from Margaret the volunteer into Dr. Chen the trauma surgeon. The transformation had taken less than a minute, but the preparation had taken 3 years. And that preparation had made all the difference between chaos and coordination, between panic and precision, between patients who died waiting for care and patients who lived because someone who appeared to be delivering magazines was actually standing guard over their lives. So now I ask you, how many Margaret Chens work quietly among us? How many retired professionals have found ways to stay connected to their calling While the world sees only their current role, share your thoughts in the comments. Because heroes don't always announce themselves. Sometimes they spend years preparing in silence for the moment when their hidden expertise becomes the difference between tragedy and triumph. Thank you for watching Retired Soldier Stories. If this tale of hidden preparation and life-saving expertise moved you, subscribe and help us honor those who never stop serving, even when their service looks like something completely different. Until next time, remember that the volunteer who seems to be asking too many questions might be the person preparing to save your life. And sometimes the most important surgery happens not in an operating room, but in the quiet moments when someone decides to stay ready for a crisis that might never come until the day it does.